Yes, good afternoon. And so Dr. Yaffe will go in details the numbers. The good point is that we have had a second day in a row of under 300, and we've had an increase considerably in our lab testing at the same time. So we have a number of positive directions or good directions on what we're hoping to see as compared to what we were experiencing in the first early part of the week. And so we're going to talk about that in a moment, and what does that mean. So with that, I'm going to hand things over to Dr. Yaffe, who will talk about today's numbers in more detail and with more other comments. Dr. Yaffe.
Thank you. So good afternoon. Yes, we do have some good news with respect to the numbers today. Our total is 26,483 confirmed cases of COVID-19 reported in Ontario. This represents an increase of 292 cases over yesterday, which is 1.1% increase. So we have the second day in a row with an increase that's below 300 cases. And while encouraging, of course, we have to keep watching the numbers closely and ensure that this trend keeps up. In terms of the case demographics, they continue to be similar. 56% of our cases are female. Almost 41% are in people 60 years of age and older, and over 65% are people who reside in the Greater Toronto Area. Of the 292 new cases today, 82% are from 3 public health units: Toronto Public Health, Peel Public Health, and York Region Public Health. The number of healthcare workers who have tested positive to date is 17% of our cases, or 4,536 cases. Again, this is a cumulative number and not the number currently positive. We do continue to see Ontarians recovering from COVID-19, with 77%, or 20,372 cases considered resolved. We currently have 847 people in hospital. That's a reduction of 1. 150 people in ICU, and 117 of them are on a ventilator. And tragically, we do continue to see deaths related to COVID-19. To date, 2,155 deaths have been reported, which represents an increase of 32 deaths from the previous report. With respect to long-term care homes, according to Integrated Public Health Information System, or IFIS, we have 199 active outbreaks in long-term care, 4,936 confirmed cases in residents. To date, 1,721 confirmed cases in staff, 1,352 deaths reported for residents, and 4 deaths for healthcare workers. With respect to retirement homes, according to the information from the Ministry of Seniors and Accessibility, which is provided by the Retirement Homes Regulatory Authority, 51 retirement homes are in outbreak, 189 deaths reported. With respect to laboratory testing, we have completed 644,547 tests so far. In the previous day, 15,133 tests were completed, and 11,817 are currently under investigation. So with those numbers, I'll turn it over to Dr. Williams.
Okay, well, thank you. And so you can see there that our testing was up in there. So the response of individuals going out to the assessment centers has been endorsed, and people are getting tested. We encourage more to do so. And again, to call ahead and check to see if there's crowds or lineup, and to get tested in a timely as well as reasonable way, and have your questions answered by the assessment center as well. But you can also obtain those answers by still calling telehealth or by talking to your family physician or primary care provider if you want general advice about COVID and your personal situation, especially your unique health issues. You talk to your private care practitioner. The thing about the testing is that when it's up to 15,000, over 15,000 tests, normally we're just sort of getting up to that by about later on in the week. So that's a positive sign. Our positivity rate has dropped from last week highs of up around 7% and 6%. Now we're down to 3.5%. So that's one of our lower ones we've seen in a long time. Again, we have 2 days now, about the same number, 287, 292. And so that's encouraging. We didn't jump right back up, which we did last week. We went right back up over to well over 400 in the next day. And so we want to watch that and see what happens on Thursday and Friday to see if we can maintain the testing. At the same time, see our cases not rise too drastically in that regard. And that helps us to look more positively towards some aspects around the social and I guess the aspects of comments about, you heard some things about bubbling and that, so we may have some better information to get to that if this continues for the rest of this week, and we can look at that perhaps next week with our minister and with others in that regard. The other aspect there is that as you can see, a lot of the cases still tend to be, even of those smaller number, in about 4 or 5 health units, and we're looking at those numbers as well as we try to understand how that is impacting us both locally and as a province writ large. So those are the main things I wanted to comment on today, and I just then open up for questions from the media in that regard.
Okay, we'll move to the phone line for questions. Just a reminder, 1 question, 1 follow-up.
Question from Cynthia Mulligan at City TV.
Hello, Doctor. I'm working on a story about the impact of loneliness on the residents in long-term care, and I was speaking to a family who has a 98-year-old mother who's blind and can't watch TV. She's basically sitting alone in her room all day long, and they've noticed that in the last month she's gone from being very verbal and talkative to answering, with one word, and they say that she's really slipping. Alberta and Quebec have loosened restrictions so that residents can go outside and have social distant visits. Why aren't we allowing physically distant visits in long-term care homes outside?
So we have a number of aspects there, and this is under the direction of our Ministry of Long-Term Care, combined with our IMS table that deals with the current outbreaks, and you've heard some of the announcements yesterday, disturbing announcements by the Premier and from some of the Canadian Armed Forces, and the position of our Premier and our Minister on that, and the ministers in that regard. So they're very concerned about not having any other places go into that kind of situation. We have put together some documents that would permit larger, more visiting, and perhaps some more liberalization of that. Maybe there's ways they could do something, but then to have a person in that state not be near the family members, maybe not hear them well enough, might be perplexing. So I can certainly sympathize with that situation, having had family members in those institutions with certain conditions where without all that ongoing socialization, their condition can deteriorate. And this has been a concern I've had when we started back a long time ago. It's how soon can we lift this, and much to my perplexity, as the outbreaks in the long-term care facilities continue to accrue, it's certainly made it more concerning, especially we got more and more healthcare workers testing positive as well. So we're hoping, as they're seeing evidence, and Dr. Yaffe's alluded to some of those overall numbers coming down, that we could do that. And so I'm still pushing to see if that committee and the long-term care ministry would allow some liberalizing of visitation, with some caveats and protections, of course, because we don't want to go step back and have some repeats in somewhere we haven't seen it yet already, because we have all our resources working at dealing with our most concerned long-term care facilities, whether it's hospital assistance or that of the CAF. So I keep asking, and I keep being told just not quite yet, but we'll continue to advocate for that. And I know a number of people have done some letter writing in that regard, and everybody would like to see that, but not that we put people back in harm's way again. So, yeah, I know it's frustrating. It's a long haul, and I think it's way too long, but we just have to be careful. So we hope to get some news to that soon.
Maybe I could add, because I do sit on the long-term care IMS table, and they're seriously considering family visitor policies and consulting with stakeholders. So it is a balancing of risks and making sure that the conditions are optimal to allow, but I think this is something that's being very seriously considered and hopefully will happen sooner than later.
Follow-up?
Okay, thank you. I'm sure families who are listening are asking, so sooner or later, what does that mean? Like a couple of weeks, a week? And what would be the harm in allowing, a socially distant outside visits, even cars driving by with families remaining in the cars?
You'd have to ask the Ministry of Long-Term Care with respect to any details around potential timing or specifics in the policy.
Next question.
Will be from Jessica Smith at Queen's Park Briefing. Please go ahead.
Thank you. Local medical officers, they have submitted a plan to the province outlining a more regional approach to reopening. Some hard-hit regions want to have some influence over the pace of reopening, and they're looking at more specific thresholds than what the province has outlined. Dr. Williams, do you support that plan, or are you concerned that this might create a patchwork system across the province?
Yes, thank you. I did, to some of the people on the, in helping with the local MOHs doing their planning are on our public health measures table, and they have been assisting us in the plan with the staging and the different metrics that we're using to give advice on when we can move to different levels in the stages in that. I did receive a letter from one of the coordinators of it on Monday and outlined how much they support the provincial programs and the coordination leadership at the provincial level. And what they were wanting to do is they took those metrics that we have already developed and said, okay, if we put those out and look at those, just much like you've seen already, if at a local level there's some difference between health unit to health unit or from one region to the next, much like you heard sometimes earlier on where we said in phase one we would have certain things open, it could permit to open, but the City of Toronto decided not to go as quickly as that. And that's totally within the prerogative of the mayor and the medical officer of health in Toronto. So they could actually limit down on that, not go beyond what was allowed, but to put some things on. Depends on their local data and information. And I think what they're trying to do is to say, in order to be to assist in that kind of process, when there's different stages in that, what would they use among themselves to say, if we're going to do the full package, that's okay. But if you have 2 or 3 health units that are adjacent to each other, if you're saying, one, we're not going to allow this, but your next door is allowing it, how do you work with your mayors and council and with your public to say, how come they can't and we can? And so they would want to have that kind of dialogue so that they could say, maybe it's best to have these 3 together, say, well, all our outbreak and our data information is about the same, so let's all agree that we're not going to open up this thing, but we're going to do the others. But that's different than our peers over on the other side of the corner of the province, and they're doing something different. So they feel the need to support the provincial program to say if we're going to have any variation, it should be thought through and consistent with the provincial metrics, but in a way that we could work with our mayors and councils and Board of Health to say if we had to limit even further, we would do it in a way that would support the provincial programs, at the same time be able to explain to the public and to their municipal councils that they're working with to give a reason why they were doing this and not that at that time, whether it's on a health unit by themselves or with 2 or 3 that are in about the same geographical region, if you may. So I saw it as more of as a positive thing, much like people see a direction and saying, okay, how do we get ourselves together to support that even better at the local level? And they hadn't yet completed the document. As I could see, a lot of the metrics weren't completed yet, and they're just in the process of trying to refine that further. And we're planning to send and forward that to our public health measures table. But I guess it went to the media in some other way. But my overall approach, I think it's a good thing they're doing. And they're keeping me advised of it, and that's important. So I appreciate the work they're doing in that regard.
Okay, follow up, and if you can speak up, please, that would be great.
I will try. Thanks, Toby. My follow-up to this is those two prongs. Does the fact that this happened from the local medical officers of health suggest that they weren't consulted well enough the first time the province released its plan? And as well, does it also suggest that the province perhaps should have outlined its own specific thresholds for reopening in the first place?
No, as I said, the ones who are helping to do this at this document are some of the ones who sat at our public health measures table to put together those metrics. And as I said, the documents they developed mirrors all those metrics as we've laid out in provincial one. They're hoping to have some other ones added to that would be very much local health unit ones. They haven't done that yet. So, no, I think it was more that they saw that direction and wanted to be stepping up and being supportive of the provincial direction so that they could do it in a consistent way and matching with the province, because some of their members are the same ones that sit on our public health measures table. So it's a very much a tighter coordination. So I see it quite differently.
Next question.
From Jeff Gray at the Globe and Mail. Please go ahead.
Thanks, doctors. I wanted to follow up on those questions about this stuff from the medical officers of health. From what I could see in there, there's a lot of very specific metrics that seem to drill a lot deeper on numbers that we need to hit in order to continue reopening. And the suggestion was that the province hasn't put out any sort of such specific numbers that the public can look at and say, oh, well, we've had X number of deaths or X number of ICU admissions, so therefore I can see why we're going to reopen stores X, Y, and Z or whatever next week. Can you talk about where are we at on that as far as actually laying out criteria that we'll be able to judge how well we're doing, and then we can see, I can see why we're opening X, Y, and Z.
So there's two parts to that. One is that we do have a large number of metrics that we are using, some which we do publish and some that we do calculate. We've talked about the R-naught calculation. We've talked about how we break that down by regions. We've talked about, we always have reports on what our provincial ICU usage is, our hospitalization usage, the ventilator usage. We talk about different aspects around public health capacity and case contact management. There's a variety of aspects there, case positivity, all those things that are in those charts that they have there. I think what they're looking at there to say, do we have the breakdown, like, for example, the ICU admission rate in London? We don't actually put those out. I'm sure that the Medical Officer of Health in London could get that data, and that may give a better indication of more granular with the same metrics down at their local health unit level or local regional level. Some local health units don't have an ICU per se, but they share one in the local area. So that the question is that, can they take those same ones and populate those down to a local area, which we haven't been doing up till now. That would be okay to do that in that regard, because that would then, they're following the consistent same ones that we're using at the provincial one to give guidance to the command table, as well as to the Minister of Health and to the government writ large. So they're very much similar, but not down to the actual local health unit or local regional level in all those aspects. And I think they're looking to see if they can develop those.
Follow up?
And just follow up, I think that the Minister of Health and the Premier today said that when asked about this stuff, they said, well, local medical officers of health are free now to have stricter rules, stricter restrictions than the rest of the province. But I wanted to put to you, I think you alluded to this in another press conference, that wouldn't that create a confusing series of messages coming from the Premier, coming from you, coming from whoever, if stores are not open in Toronto but they are in York Region or whatever?
Right, and I think that that question was in the context of having different stages, so that if you said one part of the province was in stage 2, let's say, and the others in stage 1 or vice versa, the wide variety of things that are open would make it confusing for the public. And so up till now, we've decided to move the stages in a lockstep in a provincial-wide area in there. I think that was the context of it. I think I used the example of like right now in stage 1, we don't have hair salons open, and we may have that open in stage 2. If we put one right next to each other, one had them open, one had them closed, the public would say, what's the difference? If we're saying we're going to have something in stage 1, we're allowing the following things to open up. And like you heard in Toronto, there might have been concerns about some aspects with parks and some of the amenities in parks. They wanted to, like the toys and the climbing stuff. They didn't want to open those up too soon, or some others may have wanted to do that. It's permissive that they could, but it doesn't obligate the municipality that they have to do everything in that one there. So there's a sort of an umbrella in the stage, but within that, as the Premier and the Minister said, medical officers of health understand their responsibilities, and they're reporting to the local boards of health, and some which are municipal councils, could choose on that direction to limit down some of the allowability of some things because of some local information material that they're aware of, and through the consultation with their municipal councils and boards would want to hold off for at that moment. So I think there's two different things there. Would that help you?
Yeah, no, I understand what you're saying. Thank you.
Okay, we're going to move to the last reporter on the line.
From Derek Denarin at CBC News. Please go ahead.
Thanks for the time. This question is for Dr. Williams. So yesterday the Premier said he worries about releasing hotspot data for fear of stigmatizing certain neighborhoods, but other provinces in Canada and countries around the world are sharing that type of data that Ontario isn't. Things like local testing numbers and contact tracing details. So why are Ontarians only getting the big picture on COVID?
So I'm trying to think of an example that you're using there, and I'm trying to think of others that have released data down to like neighborhoods in a city. Some release city data, and we do that every week. We tell you what Toronto's getting, we tell you what Peel's getting, so we're already more granular than many of the others are in that regard. When you're talking about hotspots and that, we're trying to look at because part of the thing in Ontario, we do a case contact that is much more granular than some other areas do. We go down to details. We do some what we call hypothesis generation, and we look at to say, if you have cases, where did they get it from, rather than just seeing who they gave it to. And you may find that you have a number of people in an area because they have the same postal code. When you go and interview them, you find that those people all work at other companies that have outbreaks going on in other parts. They may not even be in their own health unit. And so by happenstance, they live in the same neighborhood. Does that mean that neighborhood has a problem, or that the people went and worked in different companies that happen to have outbreaks in those companies? So I think it adds to your data. It helps you to analyze it a little bit better. And you may say, well, in this area here, there seems to be more. And we found around this locale, there's actually was a store or retailer that we checking out with our public health inspectors that, unlike what we recommended, they were not cautious in limiting patrons in the place. They had a sale or something. There was a crowd in it, and a whole bunch of people went in without face covering, all sorts of stuff, 2 days, 3, 4, or 5 days ago, and now we're seeing these cases. So we've tracked it back. It's not because the street is the problem. A retailer in the area was the problem. And now we have to say, not only are those 5, we have to ask everybody else who was in that facility during that day will have to go and get assessed. And that means we're going to find even more cases. That's what that investigative type of case management does in that regard. So in a way, the store would be the hot spot in that scenario, or the company in another place would be the hot spot, assuming that a company, not everybody lives just around the corner. They travel and commute to it. So hotspots have different meanings in different ways, and I think you have to make sure you use it properly. And saying that just because you happen to have people who go and work at places where there's outbreaks, the neighborhood's bad, that would be an improper assertion, and in fact could be stigmatizing inappropriately. So there's hotspots and there's definitions on how that means things, and I think it's all part of that a very quality investigative aspect that public health in Ontario especially is equipped for and good at doing.
Follow up, and this is the last question.
Nope, I'm good. That's all. Thanks.